Cerebrospinal fluid examination. The topic will be studied under the following headings. We'll study how to collect the specimen, the gross examination, microscopic examination, chemical examination, and microbiological examination. In this video, we will study about the specimen collection and the gross examination. Firstly, going to the introduction, the cerebrospinal fluid is mostly derived from the choroid plexus. The function of the CSF is to protect the brain and the spinal cord. It collects the waste, circulates the nutrients, and lubricates the CNS. The CSF was produced by choroid plexus as we discussed, and it is absorbed by the arachnoidal villi. The total adult volume, it varies from 90 to 150 ml. In neonates, the volume is less, it is 10 to 60 ml, and this volume is replaced every 5 to 7 hours. Now we will study about the CSF circulation. The CSF is produced in the lateral ventricle. From lateral ventricle, it goes via the foramen of Monro to the third ventricle. From third ventricle via cerebral aqueduct, it goes to the fourth ventricle, and via foramen of Magendie and Leshka, it goes to the subarachnoid space. Now we'll study how to collect the specimen of CSF. It can be obtained by various routes. Begin lumbar puncture, cisternal, lateral cervical, or through any cannulas or shunts which are inserted in the person. Although any route can be used, but the safest option is doing a lumbar puncture or a spinal tap. As the collection of CSF is an invasive procedure, it should be performed under aseptic conditions. In this, the person should either be sitting up for the lumbar puncture. The patient is either sitting up or should lie on the side with his back arched so that the head almost touches the knees in order to separate the lumbar vertebra during the procedure. The needle is then inserted at the level of L4 to L5 with the bevel of the needle facing up. Now we will remove around 3 to 4 ml of CSF in 3 separate tubes. It is important to know that the different tubes are used, and the CSF specimen is collected into 3 serially collected sterile tubes. The first tube is sent for chemistry and immunological studies. The second tube goes for microbiological studies, and the third tube goes for the cell count and differential count. It is very important to know that tube 1 should not be used for the microbiological studies as it can be contaminated by normal flora of the skin. And also tube 1 should not be used for the cell counting as because of any traumatic tap, the peripheral blood can be mixed with CSF and it can alter the findings. Then glass tubes also should not be used as glass leads to cell adhesion and it can affect the cell count. Now the recommended CSF tests. Firstly, we do routine tests in almost all of the patients that are total cell count, differential cell count, glucose level, total protein level, and some tests are useful only under the certain conditions like cultures, enzyme level, fungal and bacterial antigen, specific protein, and VDRL antigen for syphilis. Now we will go to the opening pressure. To know the opening pressure of the CSF, a manometer should be attached prior to the fluid removal to record it. The normal opening pressure in adults is 90 to 180 millimeters of water, and it is less in children, around 10 to 100 millimeters of water. Now, if there is elevated pressure and the pressure is more than 250, it is diagnostic of intracranial hypertension, and it is seen in conditions like congestive heart failure, meningitis, superior vena cava syndrome, cerebral edema, any mass lesion, and There can be decreased pressure. It is seen in dehydration, circulatory collapse, and in cases of CSF leakage. Now we will go to the gross examination. Gross examination, normally the CSF is crystal clear and colorless, but the abnormal CSF. Now abnormal CSF can look like, it can be turbid or cloudy. Mostly if WBC count are over 200 cells per microliter, the CSF gives a turbid appearance. It can be bloody. In bloody, we have many DDs, means differential diagnosis. It can be due to traumatic spinal tap. It can be subarachnoid hemorrhage. It can be due to intracerebral hemorrhage or cerebral infarct. There can be also seen is the clot formation. The clot formation is seen in traumatic tap or suppurative or tubercular meningitis. In tubercular meningitis, the CSF has a typical appearance and there is a formation of a cobweb, and its appearance is known as cobweb appearance. Now there are other supernatant color of CSF, like it can be pink, it can be yellow, orange, yellow, green, brown in different conditions. Like brown is seen in meningeal metastatic melanoma. Yellow to yellow greenish is seen in hyperbilirubinemia, and pink or orange can be seen in cases of RBC lysis. So we have to differentiate the bloody CSF. So a traumatic tap can occur in around 20% of the lumbar punctures. That is that it is iatrogenically induced. So we have to distinguish the traumatic tap from the pathological hemorrhage. So what things we will notice so that we can differentiate the traumatic tap from the pathological hemorrhage. First is, in traumatic tap, the hemorrhagic fluid usually clears between first and third collected tubes, but it relatively remains uniform in the subarachnoid hemorrhage. That means that in traumatic tap, the first tube will have more reddish color than the last tube, whereas it will be uniform in the cases of subarachnoid hemorrhage. Second is erythrophagocytosis. Erythrophagocytosis, they indicate subarachnoid bleed and not traumatic tap, because RBCs need to stay for some time to be engulfed by a macrophage. And there are specific tests to distinguish, like latex agglutination test, which is specific for fibrin degradation and is negative in traumatic tap. We will discuss further microbiological examination in the next video. Please like and subscribe to my channel. Thank you.